Welcome back to All About RX. Today we are breaking down one of the absolutely most critical concepts in biopharmaceutics, and that is dissolution. Whether you are preparing for your exams or focusing on clinical practice, really understanding how a solid drug turns into a solution in the GI tract is just essential. We've got a lot of high-yield info to cover in this explainer, so let's dive right in. Here is our roadmap for today's masterclass. We'll be defining dissolution, breaking down the Noyes-Whitney Equation, exploring the main factors affecting the process, and wrapping up with a quick recall summary.
Part 1. Defining dissolution. Let's get right to our foundation.
At its core, dissolution is the process where a solid drug substance becomes a homogeneous mixture right at the molecular level. Think about what happens when you take a pill. The drug molecules literally have to break away from their solid surface, and then they have to diffuse through a tiny boundary layer just to reach the bulk fluid. For orally administered drugs, this right here is the major rate-limiting step for absorption. It's the primary bottleneck. Now, to keep everything flowing smoothly, the body relies on something called sink conditions. Basically, this means the dissolved drug concentration is kept strictly below 10 to 30% of its saturation solubility. Why does that even matter? Well, if the GI fluid gets too saturated, dissolution just completely stalls out. Luckily, the body maintains these sink conditions through constant dilution and rapid systemic absorption, ensuring the drug keeps on dissolving. Section 2, the Noyes-Whitney Equation and modeling absorption. Let's talk about the Noyes-Whitney Equation. This is the absolute master formula for dissolution. Let's break down the variables real quick. The term dC over dt, that's your actual dissolution rate. D is the diffusion coefficient, which is how easily molecules move through the solvent. A is the surface area of the drug particle. H is the diffusion layer thickness, that boundary we just talked about. And Cs minus C is your concentration gradient. Take just a second to mentally process how these variables relate to each other because they completely dictate the speed of the process. The big takeaway here is pretty straightforward. Remember, if you increase the surface area, or you bump up the temperature, which boosts that diffusion coefficient, your dissolution rate increases. It's faster. But on the flip side, if you increase the diffusion layer thickness, maybe from a lack of GI motility, that rate is going to actively slow down. Section 3, factors affecting dissolution, specifically looking at environment and formulation. Depending on the dosage form we're dealing with, we actually apply different baseline models. Noyes-Whitney is our general go-to. But we use the Hicks and Crewell model for shrinking particles, since their surface area is constantly changing as they dissolve. For immediate release tablets, we might use a first-order concentration-dependent rate. And for those fancy controlled release meds, we're aiming for a zero-order constant release rate. Diving into the physical-chemical factors, polymorphism is a huge deal. Not all solid forms are created equal. Amorphous forms dissolve the fastest, hands down. Why? Because they completely lack a tight-ordered crystal structure. They have a random structure with super high internal energy, making it so much easier for solvent molecules to pull the drug apart, especially compared to their tightly packed, highly stable counterparts. Then we have the formulation side of things. How a tablet is physically built makes a massive difference. High compression forces and the addition of binders pack a tablet incredibly tightly. That drops the porosity and totally slows down dissolution. But disintegrants, they do the exact opposite. They rapidly draw in water and essentially burst the tablet apart into fine particles, which massively increases the surface area for way faster dissolution. We also have other highly specific formulation levers. Adding hydrophobic lubricants like magnesium stearate can actually repel water and slow things down. But throw in some surfactants and you improve the wetting, which speeds the whole process up. We can also use solid dispersions to lock a drug into that fast-dissolving amorphous form we just mentioned. And of course, enteric coatings are designed to completely block dissolution in stomach acid, saving the drug until it hits the alkaline intestine, which perfectly tees up our physiological factors. The drug's journey through the GI tract dictates its solubility purely based on regional pH. The stomach is highly acidic, right around pH 1 to 3, while the intestines are much more alkaline, sitting between 6 and 7.5. Because of this, weak bases dissolve beautifully in the acidic stomach. Weak acids, though, will struggle in the stomach, but dissolve super fast once they reach the higher pH of the intestines. And lastly, patient-specific variables change the game entirely. Faster gastric emptying means the drug gets to the absorptive surface of the intestines sooner. Then there's the food effect. Eating a high-fat meal triggers bile salts, and these act as incredible natural surfactants that solubilize highly lipophilic BCS class II drugs.
Plus, a higher volume of GI fluid helps aggressively maintain those sink conditions we talked about earlier. Section 4, our quick recall summary and key takeaways. Let's wrap this up. Let's do a quick refresh of the absolute high-yield facts you need for exams and practice. Remember, amorphous beats stable polymorphs in dissolution rate every time. Sink conditions are successfully maintained when the dissolved concentration is strictly below 10 to 30% of saturation solubility. Noyes-Whitney variables directly control that rate. High compression force decreases porosity, slowing things down. Bile salts act as natural surfactants to enhance BCS Class II drugs. And finally, keep in mind exactly how pH influences the dissolution of weak acids versus weak bases. As you review your notes, I want to leave you with this provocative clinical question. If you were tasked with formulating a poorly soluble weak acid, exactly how would you manipulate those Noyes-Whitney variables, and what formulation levers would you pull to guarantee rapid clinical absorption? Think about surface area, think about disintegrants, and think about GI pH. If you found this breakdown helpful, don't forget to like, share, and subscribe to AllAboutRx for more pharmacy lectures. Check the link in the bio for